UZ Brussel is a medium to large sized hospital in Belgium. We have 721 beds, in which we have about 60,000 admissions per year, half of which are one-day clinics. We have approximately 500,000 outpatient visits per year. We have 4,000 people staff, more or less, 450 doctors and 250 trainees, medical trainees. In terms of other activities, we have quite a large and a busy emergency department where we see about 80,000 emergencies and emergency contacts per year. The volume of the hospital in terms of budgets is about 650 million euros per year. In terms of innovation, I always like to quote late Clayton Christensen, who more than 10 years ago said that in order to survive, hospitals will have to be innovative. I always remember that, and then the question is, what is innovation? It's not a separate department. It's a way of thinking and a way of acting. And we try to follow the idea that about 70% of resources that we use in innovation, that means people, budgets, etc., is in the improvement of our daily operations, because healthcare and hospitals are not very cost efficient.
We work on 3 horizons of innovation. The first one is the Horizon 1, and we call that continuous improvement. So that are solutions that are already actually implemented in the organization, but where we can have better solutions for the future. So this is continuous improvement of processes or products. This is about 70% of what we should spend within the organization and time on continuous improvements. Then we have Horizon 2, which is really novel innovation that is actually known on the market, but novel for our organization. So there we collaborate with companies, we co-create and we collaborate with companies to introduce new items, new products, new processes in the organization. This is about 20% of items that we are introducing. And then the third horizon is the disruptive innovation. There it's really like very challenging. There we work more together with universities and mainly our own university, the Vrije Universiteit Brussel, where we have many collaborative projects, and that's about 10% of our innovation part. What we would like to do in the future, we find it very important that the people within the different services actually support an idea that is then going to be a project, and we would like to do it more in a gamification way in the future, that people, so that ideas are launched and that people can vote for some ideas, whether they find it important for the organization or not. We are currently looking for software to support this. But then it's more sustainable project with a result that will be implemented that people also support, because now sometimes we have projects that we are launching and not all stakeholders have always been involved. So we need to change that also for in the future. We want involvement of all the stakeholders, but that they can also choose whether this is really a solution that we want to go for. So that it's not only the innovation board, let's say, that decides, that it's supported from bottoms up by the people, and then we think it will be much more easily implemented and used, the solution.
The project that we are talking about today, we call it the connected ambulance or the ambulance of the future. Actually, this project was set up 1 year ago with a collaboration of our research group, our clinical department, and then several industry partners. What was the aim? The aim was creating an ambulance specifically developed for inter-hospital transport of critically ill patients. These transports are very difficult to do. These patients are very unstable and they need a special way of transporting them from a certain hospital to another hospital where they can provide a certain technique which was not possible in the first hospital. How many transplants did we did? I think we did all on 1 year, we did about 300 in total. Why it's a bit unique? Because we work together with our national telecom provider Proximus, and they provided us a 5G network to which all the transmission of the data, patient data, vital parameters, etc., are transmitted from one place to another.
In the past, the three disciplines, clinical chemist, hematology, and microbiology, they worked really very independently. But now technology evolved and we had the opportunity to consolidate the routine activities of these three disciplines within one automation lab. So now having this 24/7 lab, we have the ability to give a higher service to the clinicians. Patients will have more rapidly their diagnosis and their therapy, so it's of course very interesting for very ill patients. The first challenges are to still improve automatic processes. We still have a lot of processes, or partly processes, done manually, and that we want to change. But these are of course exceptions and needs more attention in programmation for our LIS.
The medical world is very conservative and is very reluctant to change. We are not Apple or Amazon or Google. And that is because of the medical training. Primum non nocere, so first do no harm. So you're trained to contain the risks. So it's very difficult to introduce something new. Innovation and especially application of innovative treatments or processes is something that is not so easy in the medical environment. That is the main challenge, to keep the engine running, to give fuel to people who want to improve things, because status quo is dead per definition. If nothing changes anymore, then you're dead. So in order to stay alive, which metaphorical, a little bit metaphorical as a hospital, you have to keep the metabolism running and you have to feed and give energy. There's this nice cartoon, somebody asks, who wants change? Everybody says yes. Who wants to change? Nobody raises his hand. And the third question is, who wants to lead the change? And everybody runs away. So that is so typical. Changing environment is not the environment where we feel comfortable. The keys to success in this story, I think it starts at the top in the C-suite. The C-suite has to be convinced that you should invest in this kind of attitude, innovative attitude. And then you have the bottom-up approach of people who are allowed to come up with ideas because they know their business. I don't know their business. They are the experts in their field, so they can come up with ideas like, why am I doing this like this? Yeah, because I'm doing it like this for 20 years. No, you can reimagine new ways of doing things.